Hi, my name is Terry Duran and I'm a family nurse practitioner. And in this teaching, we're going to talk about wandering and elopement. So the objectives of this course are to define wandering and elopement and how it relates to dementia. We're going to discuss general principles for policies and procedures of long-term care facilities, and we're going to learn about resident elopement assessment, prevention, and response. So wandering is generally characterized by excessive walking that has a tendency to lead to safety concerns, or maybe just generally nuance issues, which means that it can be basically annoying or inconvenient. It is a purposeful behavior triggered by a desire to fulfill a need. So this could be a physical discomfort. So for example, a need to urinate. It could be an emotional discomfort or the need for more or less stimulation. So this is often linked to dementia. So the Alzheimer's Association states that about 6 in 10 people with dementia will wander. So a person with Alzheimer's may not remember his name or her address and can become disoriented even in familiar places. The issue is that this can be very dangerous. In fact, wandering may represent the greatest safety risk to older adults with dementia. For example, it increases their risk of death or injury. Nursing home residents who wander have double the risk of fracture compared with residents who do not wander. Lesser adverse outcomes of wandering include undocumented falls, which can lead to other injuries, weight loss, abuse by other residents, social isolation, and all of these are serious concerns. However, there are some benefits of wandering in a safe environment. They get exercise, so that promotes circulation and oxygenation, and it also decreases contractures. There are certain risk factors for wandering in dementia. Residents who are of an older age tend to wander more. Men also seem to wander more. Those who have irregular sleep patterns tend to wander more. Those residents who have expressed more behavioral changes such as aggression and agitation wander more. Those who are more socially active and outgoing before dementia tend to wander more. Residents who have unmet physical needs such as pain or physical discomfort, or they simply need to go to the bathroom. Those who have unmet psychosocial needs such as the need to find a place of safety or someone familiar. Or maybe they're just experiencing stress. And there's other environmental factors. When a resident moves into a long-term care facility, they are at especially increased risk of wandering because they are in an unfamiliar environment. Maybe there have been some medication changes. Maybe they are left alone more. There are changes in that schedule and in their familiar routine. They are spatially disoriented to their familiar cues. And they may demonstrate a desire to get back to a past practice. For example, they just want to go home. They're in this unfamiliar place. I do want to mention sleep disturbances and sundowning. Now, some people with Alzheimer's may have problems sleeping or increases in behavioral problems that begin at dusk and last into the night. And this is known as sundowning. And a few people will wander at night. Now, scientists don't completely understand why these sleep disturbances occur with Alzheimer's disease and dementia. As with changes in memory and behavior, sleep changes somehow result from the impact of Alzheimer's on the brain. So this nighttime restlessness doesn't last forever. It typically peaks in the middle stages of Alzheimer's and then diminishes as the disease progresses. Elopement is a type of unsupervised wandering when a resident leaves the long-term care facility and does not return. And this is considered the most dangerous type of wandering. Now, residents are least likely to elope between 12 a.m. and 7 a.m. The majority of those who elope are repeat offenders, with approximately 72% of successful elopers attempting to do so again. A review of elopement claims against nursing homes found that 80% of involved residents were described as chronic wanderers. Also, 45% of incidents for which claims were filed occurred within 48 hours of admission. Every facility will have its own policies and procedures, so I will just go over some general principles and I will give some examples. Policies should reflect an interdisciplinary approach, with a team being involved in the initial and ongoing risk assessments, care planning, and resident, family, and staff education. For taking photographs of the residents at risk for wandering, it is advisable for it to be clearly spelled out who takes the pictures and when, and the process by which photographs are updated and maintained. For elopement risk assessment tools and forms, it is appropriate and useful for the relevant MDS items to be referenced. Policies should address how all staff will know if a resident is appropriate to be off a unit or outdoors unsupervised, and what actions to take if he or she is in a potentially unsafe situation. It is also helpful if there are criteria specified in the resident's plan of care when interventions are to be implemented. It is also helpful if there are criteria for how often, where, and when missing resident drills are conducted, as well as a defined system for determining the frequency and the type and location of these drills. These factors may be based on criteria that the facility establishes, which can include elopements such as the time of year, the resident population at risk, and the outcomes of the drills. So the Facility Quality Assurance Committee is the appropriate body to drive these determinations. Also, if the alarms are ever disengaged, so like if there's a repair going on, then the facility should consider what backup systems exist to safeguard residents in the interim. For example, if an exit alarm is disengaged for a delivery, the area should be cordoned off during that period of time. Facilities should also consider what the process is for determining which residents have a personal alarm in place, who will do the daily maintenance checks, and where those checks are documented. Facilities should consider when a resident is determined missing. This is a very important, and it needs to be spelled out in the facility policies. Time is not necessarily the determining factors. Facilities should consider conducting an immediate root cause analysis when an elopement occurs. And policies should indicate when an elopement is reported to the Department of Health and other authorities. Now, most of us don't realize the importance of quality improvement guidelines. Most long-term care facility workers don't realize how important quality improvement is. So if your healthcare facility does not have a very good wandering elopement policy and procedure program in place, I do want to refer you to the elopement manual link that I have provided for you here. That's where a lot of this information is from. And it is an excellent resource. It is a little bit older, but it still completely applies to everything today. So that's where some of this information is from. And it's all publicly available in a Word document. So I would refer you to that. So some quality improvement guidelines. So the goal of all of this is resident safety and risk management. And this should be inherent in each skilled nursing facility quality improvement program. So the following ideas are to be reviewed and incorporated in the safety risk management aspect of a skilled nursing facilities quality improvement process. So establish a proactive, prevented method of quality improvement. Establish specific, practical, and effective policies and procedures that will assist in preventing the monitoring aspect of this program. And monitor the effectiveness of the elopement and wandering program by sampling assessments, care plans, and outcomes concurrently to identify if the facility policy and procedures are being followed and establish compliance. Conduct drills periodically to evaluate the effectiveness of the missing residence procedure and staff knowledge of the level of these procedures. Also monitor compliance to provide education as described in facility policy. Evaluate the learning objectives of the orientation program and any other education of staff related to this topic. This can be done by monitoring a few key questions related to the materials after each class and at intervals ongoing in practice settings. Monitor the effectiveness of the environmental methods used to prevent elopement on a periodic basis. After each incident of elopement or near miss elopements, individually but also collectively identify any resident or facility trends. Also, utilize the facility's policies, procedures, and standards to assist in evaluating the effectiveness of these facility standards and to keep the process simplified. As far as staff training goes, it is recommended that all facility staff should receive in-service training regarding the facility's resident elopement policies within 30 days of employment, and that all staff should be given a copy of the facility's resident elopement policies and procedures. But that education should be ongoing in the form of drills. So all facility staff shall demonstrate an understanding and competency in the implementation of the elopement policies and procedures. So resident elopement drills should be conducted at least twice a year, are the recommendations. So the administrators and the direct care staff must participate in the drills, which shall continue a review of procedures to address resident elopement. Facilities must document the implementation of the drills and ensure that the drills are conducted in a manner consistent with the facility's resident elopement policies and procedures. Participation in these drills shall be documented and kept in the staff records, and discrepancies and or weakness revealed through the drills will be corrected. And this is just an example of some of the recommendations. So let's look at elopement risk assessment. Now, before a new resident is even admitted to a facility, all skilled nursing facilities are required by law to conduct a resident admission assessment. So a facility should base its admission criteria on its ability to protect residents, given the security systems in place and elopement assessment findings. Must demonstrate that the resident's level of risk is in proportion with the facility's elopement prevention strategies. So in other words, if the facility does not have the systems in place to handle the wandering resident, they should never be admitted to the facility in the first place. There are several elopement risk assessment tools. One of the most popular is called the Doing Wandering Risk Assessment. So this breaks down wandering into 5 main categories. It's no risk, low probable risk, moderate actual risk, significant actual risk, and serious actual risk. Now, my favorite, and this is actually what the elopement manual uses, is called the elopement risk decision tree. Now, this is also used frequently, and this involves a series of questions, and it leads you through steps. By step 4, full interventions are required for elopement prevention. Another one that is used is called the revised Algace wandering scale. This is comprised of 28 questions, and this measures 5-dimensional factors, including persistent walking, spatial disorientation, eloping behavior, routine walking, shadowing with moderate reliability, and validity suiting at long-term care centers. There is also another one called the risk of wandering scale. Now, it really doesn't matter what tool is used to identify the risk for wandering and elopement, but the task force of the National Council of Certified Dementia Practitioners recommend that whatever tool is used, the following question should always be asked. So, is the resident independently mobile? So if they are bedridden, of course, you do not have to worry about wandering. Is the resident cognitively intact? So if they have no memory issues, then of course they're at low risk for wandering. So does the resident have competent decision-making capability? Does the resident wander? So for example, my grandma had Alzheimer's, but she did not have any type of wandering behavior. Does the resident have exit-seeking behavior? Is there a past history of wandering or exiting a home or facility without the needed supervision? So sometimes people seek long-term care in a long-term care facility because the spouse is wandering. Does the resident accept their current residency in the facility? Does the resident verbalize a desire to leave? Has the resident asked questions about the facility's rules about leaving the facility? Is there a special event or an anniversary coming due that the resident normally would go to? And is the resident exhibiting restlessness or agitation? So answering yes to one of these questions or a combination of them can identify the resident at risk for wandering and potential elopement. So these questions can be integrated into the overall assessment, as some of them are already asked in the minimum data set. So remember, a person should never be admitted to the facility if the facility is not equipped and the staff is not trained to handle wandering behaviors. So before we talk about elopement prevention, there's something that I always want you to remember. That studies show that 45% of elopement legal claims filed occur within 48 hours of admission to the long-term care facility. So when we talk about elopement prevention, after admission, elopement risk should be recorded in a readily identifiable section of the resident's chart. And the facility should institute a reliable mechanism for notifying all staff of high-risk residents. Staff members not directly involved in resident care, new employees, per diem staff, and all visitors should be informed of the facility's policies and procedures for preventing wandering. For example, uninformed visitors could inadvertently compromise the safety measures in place by allowing dementia patients to pass through routinely locked doors, even a front entrance. Now, by law, long-term care facilities must develop and implement a baseline care plan for each resident within 48 hours of admission. So I just wanted to give you an idea of a sample care plan. So in the 3 columns, you will see the resident concern, the resident goal, and the staff approaches. So obviously the resident concern would be wandering and elopement. So the evidence would be that the resident verbalizes intent to leave the building. You would already know that they wander, you know that they try to leave the unit, and they verbalize that they want to go home. So this would be related to maybe they have roommate problems, they have chronic pain, they voice frustration. So any one of those. They're a new admission, and so they've had a change of environment. They've got a history of elopement prior to admission, maybe at home. They were leaving the home or trying to get out of the home. Maybe there has been a personal loss or bad news. Again, this is just an example. So maybe they have some strengths and preferences. Maybe they have a need to walk even at nighttime. Maybe they sundown. One of the most important things to do in their life was to take long walks in the woods with family. Maybe that's something that they enjoyed, or they enjoyed hiking. Maybe they're still strong and steady on their feet, and maybe they have some strong family involvement. So a goal would be the resident will continue to walk in a safe environment. Maybe the resident will accept walking with assistance from the staff when the resident is tired or needs direction, and the resident will remain safe within the facility. So the nursing and the team could determine the resident's walking patterns. So is it more during the day, more during the night? The nursing, the activities director, the support staff, physical therapy could try to identify triggers indicating the resident's need for walking. So is it that they need to go to the bathroom? Do they have uncontrolled pain? Maybe they can't verbalize that. The nursing or PT activity support staff could evaluate the unit and the facility for potential hazards for this resident. On different days, different people could be assigned to walk with the resident after lunch daily on the grounds. Now, family could come in and do this on a Saturday or Sunday, or even volunteers could do this that come to the long-term care facility. The activities director could offer resident participation in maybe a walking club. The activities team and their support staff could make sure that the resident is taken on the nature trips, the apple picking, the leaf looking. I know my grandma, there was this place called the Post Family Farm, and they would always go there from her long-term care facility, and she would go, or they would go to the park. Really important more in the beginning is to obtain the wandering history and patterns from the family. This would be mainly a nursing thing, but the support staff could also ask the family their wandering patterns. Dietary could provide the resident with their normal coffee and pastry that they've always had throughout life in the morning. Maybe they would get up, they would have coffee, something to eat in the morning, and the paper each morning in the lounge area. Maybe in the afternoon, they would always have a snack before supper. So maybe just trying to get some of those routine activities that the patient has always had throughout their life. Maybe the resident has always liked to watch field and stream videos or look at magazines, or maybe they could look at family albums and videos when they appear overly tired from walking. So this would be something for the activities staff or the support staff or family. Maybe nursing could be involved in this. The team could encourage the resident to participate in all the activities that the long-term care facility provides. And of course, nursing and the nursing staff can just make sure that the bracelets or whatever the long-term facility has, so in this case it would be the WanderGuard bracelet, is always present on the resident's arm. In other words, it's always important to take an individualized approach to minimize wandering and elopement risk. So the staff should attend to the at-risk residents' specific physical, social, and emotional needs. So they should be taught to be especially responsive to patients with dementia who exhibit behaviors such as excessive walking, those that show signs of anxiety or agitation, or verbalize a need to get home. Staff members should learn to recognize and promptly resolve the resident's hunger, thirst and toileting urges and seek to optimize the surrounding climate and noise levels for the residents likely to wander. Also, mealtime interventions such as encouraging the at-risk resident to sit at the table with other residents rather than eating alone in his or her room, and providing greater staff supervision can make it harder for the resident to wander. And these changes might also result in better nutritional intake, so reducing subsequent hunger, which is an established risk factor for wandering behavior. Facilitating social contact between extroverted residents with dementia and concerned attentive staff members, friends, family, or even fellow residents can help keep these patients engaged and less inclined to wander. So encourage family members to come and visit their loved ones. Encourage the children and the grandchildren and the great-grandchildren. Because even though they can't have meaningful conversation, there's still a need for emotional connection there. So maybe they could bring a simple activity to do. Now, my son and I would visit my grandma, and she had Alzheimer's, and we had so much fun with her because my son was on the same level as her when he was a baby and he was a toddler. And we enjoyed those outings with her. We would take her out in the wheelchair. He would sit on her lap, and we would just go outside and take a walk or go out and see outside and feed the ducks. And she had so much fun with him, and he had so much fun with her, and he learned a lot from that experience. And she would babble at him, and he would babble back at her. So that's just how it went. For residents capable of movement and exercise, physical activities help them stay busy, relaxed, oriented to time and place, and interested in their surroundings. So it is important to give these residents opportunities to be active regardless of their cognitive limitations. So increasing at-risk residents' level of participation in interactive activities designed to enrich the social environment has also been shown to prevent boredom and also lessen wandering behavior. Now, one thing we want to say is that antipsychotic medications and physical restraints are not appropriate interventions for wandering behaviors. In fact, they actually increase the risk of pressure ulcers, infections, falls, and sedation, and they can actually promote anxiety, agitation, or violence. And antipsychotic medications in general have been found to increase rates of death in the elderly. Now, here are some examples of individual approaches that can even be part of the care plan. So, avoid events that lead to wandering behavior. So this would be crowded events, loud noises. Also, review medications that may cause anxiety, impair vision, or cause poor balance, such as medications that can sedate them. And there has to be ongoing assessment of their effectiveness. There's actually a whole criteria called the Beers criteria, and this is for appropriate prescribing in the elderly. There are actually many medications that can masquerade as dementia. So a healthcare provider that knows these criteria needs to look at all of their medications and make sure that they are not on them, because some of them are very common and they're called anticholinergic medications, among others. So that needs to be investigated, and anybody with memory problems should not be on those type of medications. Also, try to decorate their room with favorite pictures and books. This may provide a sense of comfort and familiarity. Have residents who wander wear a designated item of clothing so that they can be identified. For example, maybe a bright shirt or bright colors. Camouflaged doors with wallpaper or curtains so that they are not recognized as doors. Monitor response or reactions to events or activity in surroundings at the time of wandering. Anticipate needs upon wandering, so triggers and patterns. Acknowledge the resident's behaviors as an attempt to communicate needs. Encourage verbalization. Try to identify the source or the etiology and recognize feelings. Support and identify the need for wandering and develop an individualized activity plan in response. For example, a walking program or a movement program, an exercise or dance program. Again, determine the resident's walking pattern. Do they walk during the day? Do they walk during the night? Identify triggers indicating the resident's need for walking assistance. Evaluate the facility for potential hazards for the resident. Always offer the resident participation in facility activities. And make sure monitoring devices are applied correctly and functioning at all times. Provide activity at the change of shift to keep the resident busy at the time of high noise and the exiting of staff. Utilize alarmed doors at the time of meals to prevent wandering off units. Identify activities for the resident based on their past work-life habits and hobbies. Communicate the resident's potential for wandering to staff at the unit and exit areas. Assess the resident's psychological or psychiatric status, and utilize volunteers to visit with the residents. Now, as a facility to minimize wandering and elopement risk, one obvious option is to keep people in locked dementia units. So, although this may make them safer, it deprives them of freedom and is actually not a guarantee against elopement. So other facility-wide interventions might include establishing controlled indoor and outdoor areas where residents can wander freely. Some facilities actually have outdoor wander gardens. However, to promote better supervision, access to any outdoor area should be located in a central area of the living space. Another option is to have fewer residents per living area. And this has also been found to improve residents' orientation, decreasing wandering behavior by promoting their ability to navigate around the facility. Of course, signs should be posted to remind visitors not to assist residents in leaving the facility. Measures that steer wanderers towards safe environments include providing walking companions, maintaining clutter-free interior pathways, and creating enclosed exterior walkways. Clearly visible markings at the end of corridors can serve as meaningful cues on orientation for confused residents. Door locks can also be used to restrict patients to a safe area. There's also elopement warning systems, such as alarms that sound when residents leave the bed, the chair or room, or when a wheelchair is set in motion. And these are already widely used in long-term care facilities. But the sound from these electric alert devices can cue the resident to his or her behavior and interrupt an attempt to wander. But in some residents, the noise from the device might cause stress, therefore increasing the likelihood of wandering. Therefore, a better option may be the use of transmitting devices that are designed to notify the personnel when the chair, bed, and door alarms are activating, allowing the staff to intervene and avert wandering behavior without subjecting the residents to unpleasant alarms. So residents can also be equipped with transmitting wristband devices that alert the staff members when the resident nears an alarm point, or that use electromagnetism to lock doors automatically as the resident approaches. However, any automatic door locking system should be configured to deactivate during a fire emergency. By routinely screening all residents for wandering risk, facilities ensure that they only use electronic alert systems to restrict at-risk individuals, enabling those residents allowed to leave the premises to do so without any unnecessary supervision. So now let's talk about elopement response. It is very important to have a missing resident protocol in place so that the staff is aware of the procedures to follow should an event actually occur. So again, this is another example of an elopement response, and this is from the manual again. So all staff should have a responsibility and an action to follow. So if we look at the responsibility and the action, all staff should notify the highest ranking nursing personnel of the missing resident. Again, this is just an example. The highest ranking nursing personnel will direct unit staff to begin a search of the unit immediately. They'll announce from any telephone the code, so, dial whatever, 4 times and repeat it 3 times, notify security. Then a response team, upon hearing the code, will report to a designated office. The highest ranking on-site staff will assign a search sector to each team member and records the attached elopement incident search assignment form. They also should notify the administrator if needed and provide photos of the resident to security if needed. So the staff assigned to a sector, so kind of like a systematic search. So the sector search completed a report back to the command post. The highest ranking on-site staff member, when the resident is found, announce the code, canceled, and repeat that 3 times over the system. The administrator or the designee notifies the police department that a resident is missing. The nurse in charge completes the appropriate documentation, including the condition of the resident when last seen. And the administrator, the director of nursing, or the designated person needs to notify the Department of Health as per the requirements. So again, this is just an example of an elopement response. So general elopement criteria response, whatever is part of your policies and procedures, should have an internal alert system to signal staff if a resident is missing and to implement response procedures. Also consider assigning staff to specific areas and use a checklist of searched areas or shading in searched areas on a floor plan. There should also be a systematic search of the resident care units and other immediate areas. This means rooms, closets, stairwells, even those areas that are normally locked, along with the roof if there's any type of roof access. There should be a thorough search of the grounds, and also alert staff of any potential hazard areas such as parking areas, roadways, or ponds. There should be a notification of management, of family members, and physicians. There should be a notification of local police to request their assistance, and a documentation of all actions taken either at the time of the incident or immediately afterwards. Now, what should be done when the resident is located? Well, there should be a complete medical evaluation to identify potential injuries and provide necessary treatment. Also, notify any previously contacted individuals of the resident's return. There should also be an investigation to determine how the elopement occurred in order to correct any underlying contributing factors. So again, in this elopement manual, there is actually a Joint Commission framework for conducting a root cause analysis. And it's actually a great resource in there. So I definitely highly recommend it. So when we get into litigation, about 10% of all lawsuits involving long-term care facility or nursing homes deal with elopements or wandering. And 70% of these involve the death of the resident. Nursing homes are required by law to provide adequate supervision to prevent wandering and the related complications and injuries. So I want to give you about 5 examples of lawsuits. In Michigan, there was a settlement for $875,000. So the nursing staff knew of a resident's risk in developing and leaving a facility unattended. So without warning, the man used his wheelchair. He left the facility unnoticed through a broken and unlocked door late in the night during freezing temperatures, and he was basically found frozen the next morning. The lawsuit alleged that the facility was negligent in letting him exit the facility unsupervised and delayed searching. There was another lawsuit filed in Pennsylvania in 2019. The resident admitted to the facility with a known tendency to roam, left the Pennsylvania Nursing Center at night. Video surveillance revealed her walking around disoriented. Now, the lawsuit document revealed that the staff ignored alarms she triggered while leaving. The resident fell off a retaining wall and suffered a head injury while falling 2 stories onto concrete. And she was not wearing a WanderGuard bracelet when she left the facility as prescribed by her care plan, and she later died from her injuries. Another lawsuit was filed in Washington in 2017. A resident's family members believed their loved one was a roaming risk with a history of delusional thoughts. So at 10 p.m., the resident left the facility after being seen near the facility's front door. The staff allegedly did not check his room or conduct a thorough search after discovering his disappearance. So the man was found lying in the parking lot, suffering an injury from the cold. He was hospitalized before being sent back to the facility, where he died the next day. Another settlement was for $1 million in California. The family members of a resident with Alzheimer's chose the facility, believing that staff members could protect their loved one. The resident left the facility and entered a mobile home park where the resident fell. The resident contracted pneumonia from being outside, which was the cause of death. The wrongful death lawsuit alleged that the home did not have adequate staff to monitor and keep the resident inside the premises. So maybe this goes back to not even admitting the resident if the long-term care facility does not have the resources to keep the resident safe. There was another incident in New York where there was a jury verdict for $2 million. The resident left the facility and returned to a former residence where he had lived 20 years ago. The resident was suffering from renal failure requiring dialysis. So authorities found the resident ill after he had wandered into a building. In addition to alleging that the New York nursing home was negligent in allowing the resident to wander, so he is already an elopement risk, the lawsuit also claimed that the home failed to administer his medications. So in litigation, to prove a nursing home elopement, attorneys must show that the facility failed to meet the standard of care and or that they responded inappropriately when the elopement did occur. So they're going to look at 3 things. So number 1 is, were there prior elopements? So the first step in establishing a case against a facility is to see if the resident had a history of wandering or was at risk for wandering behaviors. So the Omnibus Budget Reconciliation Act of 1987 was administered by the Center for Medicare and Medicaid Services. This sets regulations for standards of care that address accident prevention and resident assessments. So nursing homes are required to identify those patients who may be at risk for wandering behaviors and to develop care plans that will help manage those behaviors. So not only must the facility perform an initial assessment when the patient first comes in, but also should reassess periodically after. Now, that is very important, this reassessment also. The second thing they're going to look at is, did the facility have a plan? So once the patient has been identified as being a risk for wandering, the nursing home is responsible for setting up appropriate interventions and strategies to monitor the patient. So appropriate interventions may include behavior logs, conducting regular supervision and checks, providing activity programs that discourage wandering tendencies, treating depression and anxiety disorders, and the implementation of alarm systems, both on the facility itself and on the patient, and if needed, having the electronic ankle or wristbands. The third thing they're going to look at is, did the facility respond appropriately? So even if the long-term care facility performed adequate assessments and established proper care, interventions, and preventative strategies, they may still be held liable for the patient's injuries or the resident's injuries if they did not respond appropriately or quickly enough to an actual elopement. Appropriate responses to an elopement include a timely reaction to the patient's absence, an efficient and complete search, and the proper notification of staff, physicians, families, and the authorities. So a nursing home abuse attorney may also want to check to see that the nursing home had a plan in place for when the elopement occurred, and if the staff was properly trained to act on that plan. So all direct care staff members, for instance, should have been aware of which residents were at risk of wandering and well trained in the actions needed to prevent and respond to an occurrence. So other areas of liability that may be looked at is whether or not there was regular inspection and maintenance of these systems. They'll look at the staffing at the time of the elopement and the level of training in elopement prevention or response procedures. They'll also look at staff failure to notice changes that indicated deterioration in mental capability that could have created a new wandering risk. And they will look at the resident chart and see if it could provide data to support this assertion. So before I finish this teaching, I really want to touch on the subject of person-centered care. And this really has to do with the importance of understanding who people truly are. So research shows that applying person-centered care principles and practices to assessment, planning, and the delivery of services can help family and paid caregivers better serve people with dementia, including those people who wander. So the principles of person-centered care include the following. So understand that the individual in people with dementia is increasingly hidden rather than lost. Acknowledge the personhood of people with dementia in providing services. Personalize the individual's care and surroundings. Involve the individual with dementia in decision-making as much as possible. Interpret behavior from the person's viewpoint. Ensure that the individual and the caregiver relationship is as important as the care tasks. Now, there are many benefits of patient-centered care, and research backs this up, that these patient-centered interventions have positive influences on staff outcomes. That means that there's more satisfaction and in the staff, and they want to provide this individualized care. There's also improvement in the psychological status of the residents, so they're less bored and they have less feelings of helplessness. It also reduces the levels of agitation in residents with dementia. So if there's reduced levels of agitation, that means there's less wandering. So when we specifically apply these principles to wandering and exit-seeking behaviors, That means that caregivers are likely to provide better services and supports when they truly know the personal story and the personal history of the individual with dementia. What were they like? What careers did they have? What type of personality did they have? Know the person's current health condition and the remaining abilities that they have. Know the conditions that trigger the wandering or exit seeking, their history, their background, and try responses to wandering and exit seeking that respond to the person's unique circumstances. So an example of this would be demonstrated through an example of an assisted living facility. So there was a resident who was entering other person's apartments without permission and taking or leaving papers there. But the staff knew that the resident had worked as a mail carrier. So what they did is they placed papers and envelopes on tables along the path that the resident usually walked. So the resident began picking up and leaving papers on the tables, and this greatly reduced the unwanted visits to other residents' apartments. Or maybe somebody used to clean homes or houses, or they enjoyed cleaning their own house. Maybe give them a rag so that they can walk around and clean the tables after lunch. So in conclusion, wandering and elopement frequently occur in long-term care facilities. It is inevitable. However, it poses serious risks for the residents with cognitive impairment and for the facility, which can be held liable if a resident leaves without permission and is injured. So in implementing measures to deter wandering and elopement, the long-term care facilities really can balance safety with autonomy and keep their residents safe. And sometimes all it takes is just some added creativity. Thank you so much for listening to this teaching. My name is Terry Duran. I'm a family nurse practitioner. And now it is time to take your quiz.